Alrighty, guys, I want to thank you all for coming today again to my presentation. I hope you guys can see my screen well. And if you can't, definitely let me know. But today I'm going to talk about something that was my first pharmacy pearl that I was like the most intrigued with. It was going to be the use of phenobarbital for alcohol withdrawal. So I'm going to go ahead and jump into this and keep us on time. So I have no real or apparent disclosures, and let's go into my objectives again. I want to review some of the pathophysiology regarding the alcohol disorder, and for others, let me get this out of my way, the assessment of acute alcohol syndrome. Then I'm going to discuss the pharmacology and kinetics of common medications used in alcohol withdrawal, particularly benzos and phenobarbital. Then we're going to analyze some clinical literature regarding the management of alcohol withdrawal. So a little background here is that we know that it's close to 76.3 million people worldwide have alcohol use disorder. These account for about 1.8 million deaths each year, and greater than 30% of the emergency department presentations are in some way or fashion alcohol related. And severe alcohol withdrawal syndrome accounts more than doubles the length of stay and frequently requires treatment in the ICU. And a complicated alcohol withdrawal syndrome includes status epilepticus or delirium tremens that occur, which might be as high as 15% in these patients. So I had to find a way to help myself understand what's going on in alcohol withdrawal. So you can see at the top part there, we're going to have this scale that we have. So we have a scale with GABA and glutamate, and for most people, we're fine. It's going to be even keel there. And then when we have intoxication, you go down to B, we have a lot more that's going to be pressing down on the GABA with that alcohol. So again, the pressing down means that there's more. It makes it a little complicated, but the pressing down of that level equals more. And then once you have a patient, you move on to that group C that has GABA plus alcohol, but they're chronic and regular alcohol users. They actually can get to the point to where they have glutamate is upregulated, but we're still at a very good place. But when we move forward and we have a withdrawal state, that's when things get very interesting. And we have that upregulation in the glutamate receptors that's kicking off and people are going crazy there. And we need to find a way to put some more weight on our GABA receptors. So when we start to look at the timeline here and what's happening to these patients, and it's gonna be pretty interesting for us because we're going to get these patients at one phase of this. So depending on the days since alcohol discontinuation, we can have some anxiety, insomnia, tremors, palpitations, things of that nature. And that could be anywhere from just a few hours after all the way through 10 days. And then you can potentially have some withdrawal seizures as well in that 2 to 4 day range. And you can have some hallucinations as well. But you start to move a little further down when it comes to having the classical signs of delirium tremens within that 4 to 10 day range. So it can really peak out, and it's not exact, but again, from the textbook standpoint, that's what we have. So what is all this? What is the diagnostic criteria? And I think that this has changed over the years, and we've seen different tests used and different things, but what is the DSM-5 diagnostic criteria for alcohol withdrawal? And you're gonna have a combination of things. So you can have group A, you can have cessation of an alcohol use disorder. You can have B, you have 2 or more of the following developing within several hours to a few days after criteria A. And you can see all of the components there. We're having the autonomic hyperactivity, increase in hand tremor, insomnia, nausea and vomiting. You have some transient visual, tactile, or auditory hallucination or illusions, and you can have some aggression and agitation, along with anxiety, and then potentially having tonic-clonic seizures. So when looking at some other things that we can use, I commonly hear CWAS. CWAS is like the big thing that we hear across the board. It's going to be what our nursing staff are using to help out from this. It's going to be the Clinical Institute Withdrawal Assessment for Alcohol Scale, and it's going to be in its revised form. And it's going to be one of the most utilized or even adapted from that utilized assessment tool. And of course, it's used to determine the severity of withdrawal symptoms as they are actively experienced. You're going to have a validated 10 items assessment tool and scores 8 to 15 indicating mild, scores greater than 20 indicating severe. Or you can have something like the MINDS. This is another scale that we can use to see how severe our patient is. And I won't go too deep into this, but we have just another scale that we can utilize. And I think for the most part, people are now making their own. I know when I was in residency, we had the GAWAs and we had the Grady alcohol withdrawal scale. And we used some variation of this to determine how severe our patients was. And then from there, we went on to be able to treat them accordingly. So before we get into talking about the difference between the different ages, I think one of the big things I want to break down is the fact that should we be giving these patients this fixed dosing across the board? And that was what we did for a period of time until this study came out in '94. And what they did was they wanted to see the impact of individualized treatment on the intensity and duration of their therapy. And what they wanted to look at was fixed schedule with lyrium or clonidine epoxide 4 times a day with PRNs versus a symptom trigger. And they use this only when signs and symptoms of alcohol withdrawal is present. And the cool thing is this is what kind of helped us change to score the patient, give the medication based off of that. And what they found within their study was the median duration of treatment in the fixed was 68 hours compared to 9 hours in the symptom trigger group. The median dose that was used was 425 milligrams compared to just 100 milligrams. And the key thing was that there was no significant differences in the severity of withdrawal, incidence of seizures, or delirium tremens. So they concluded that symptom trigger individualized therapy decreases both duration and the amount of benzodiazepines used, and is as effective as the standard fixed scheduling therapy for withdrawal. So when looking at any type of guideline recommendation, one of the things that we see here with this one that was done in 2004 is that they don't necessarily recommend particularly one exact agent over the other. So you can have sedative hypnotic drugs are recommended as the primary agent for treating. And they said that there isn't evidence to support one sedative agent that is superior to others or switching from one to another that's helpful. I may disagree slightly, but we'll talk more about that. And they say that dose these agents to like sedation and adrenergic antagonists may be considered as adjuncts. Again, I know we have a lot of people who are really jumping on that dexmedetomidine train, but again, this is just the information that we had before. So let's move into the big part. Let's talk about the pharmacology and kinetics of some of the more common agents. So we're going to have our benzodiazepines. And of course, I will just remind us and refresh us of the mechanism of action. We're going to have GABA-A enhancing activity. Again, it definitely requires GABA to be present. It's going to increase the frequency of GABA-A receptor channel opening. And of course, the agents that we see traditionally used, you're going to see lorazepam, clonidine epoxide, and diazepam. And the dose, again, I will show you guys on our next slide there, but it's going to be much higher than we use for sedation. And that's what scares a lot of people when utilizing benzodiazepines, is that for people who really are in alcohol withdrawal, you need big doses to actually get a response. The onset, depending on which one you use, can be anywhere from 2 to 10 minutes. And then again, everything's be based off the metabolism, hepatic and substrate for the isoenzymes. And the elimination is going to be primarily through the urine as metabolites. The things that we're worried about across the board is hypotension and respiratory depression. This is where, when we start giving these really big doses, we're really putting ourselves at a high risk of having respiratory depression and hypotension. So we can see we have a host of our benzos here. And if you look on our left-hand side here, we have the names of our drugs. And then we move on to the next one with the equivalent dosing of that. And then onset of action as far as how fast do these agents work. And I think we have to consider some things like whether it's going to be PO or IV. But again, we have our agents that work particularly fast. And then we move on to duration with some of these agents working a little longer or intermediate. And the ones that I point out are the big ones we use, like diazepam and lorazepam is going to be the most commonly used in my shop. And then whether they have active metabolites or not, that can really help us out when deciding which benzo we want to use. Then we have phenobarb. My pushing P right here, phenobarb. It's definitely another agent that we can use, and the mechanism of action is that it enhances binding of GABA to receptors through increasing duration of GABA-mediated receptor channels, and then at high concentrations with the big doses that we use, it may also be a GABA mimic and potentially inhibit the AMPA receptors as well. Dosing is going to be across the board. It varies depending on what you and your shop wants, but I've seen anything from, we're looking at IV, we have 65 to 260 milligrams, all the way up to 10 to 20 mg per kg. Oral, this one of the regimens that I seen was given 60 milligrams 4 times a day on day 1 and followed by taper across the board. But again, this varies quite a bit, so I was hesitant to even put that on there. What I like about Phenobarbital is the kinetics. That's the thing that really makes it unique. The onset's going to be about 5 minutes when looking at the IV formulation, and then oral is going to be 30 minutes, and then you're going to have a duration, you're going to have like anywhere from 86 to 120 hours. So it's going to last quite a bit, and I like to say that it self-tapers quite across the board. Of course, we're going to have the metabolism due to C19, and it's going to be eliminated 25 to 50% unchanged in the urine. And we're going to have the same things that we're worried about from the adverse effects standpoint: hypotension or respiratory depression. So these are most of the agents that people use in my shop when it comes to treating alcohol withdrawal. You're going to have your benzodiazepine, phenobarb. Some people are really in the love story with dexmedetomidine, and ketamine is another agent we can use as well. And we just take ourselves back and seeing what agent hit the actual pathophysiology. For me, I'm looking at benzos, phenobarbital, and ketamine that really hit those. Of course, we have various routes of administration. The dosing and the onset is listed there for you. But one of the things that you see is that we have a pretty good onset with phenobarbital, and it lasts quite a bit, and you don't have the hepatic issues like we have with using other agents like diazepam. So let's talk a little data. Now, I wanted to go and talk about a host of studies, and I had to kind of contain myself across the board, and I'm going to only talk about the first 2 that I have listed on here. But this is just an overview. You guys know I love my pharmacy pearls when it comes to this, so this is a lot this can be found there. But some of the other studies, what we can see across the board is that there may not be a huge difference. So you look at our studies, all 4 of them are going to be relatively small, but what we can see is that phenobarb may actually be just as efficacious or better, depending on which study you look at, and when looking at the actual outcome that you're looking at. So I won't spend much time here. This is just a reference slide. I'm going to go and talk about these first 2 studies because for me, those were the 2 foundational ones for me. So let's talk about this one, the Rosenson study. This was one of the big ones that got everyone interested, or I may be naive to think that everyone got interested around this time because it's around the time that I wasn't involved in pharmacy. So what they did was they wanted to investigate if a single dose, just one of phenobarb combined with the standard lorazepam-based protocol would decrease ICU admissions in ED patients. And I really love this study because they looked at those ED patients. And what it was a prospective, randomized, double-blind, placebo-controlled study. They looked at 198 patients with suspected alcohol withdrawal syndrome. So when looking at some of the methods, we saw that they included patients that were greater than 18 with suspected alcohol withdrawal. Again, for exclusions, not much other than just the study drug, allergies, hepatic impairment, no IV access or other primary diagnosis. And they used, for the intervention, IV phenobarbital, 10 mg per kg and 100 mL over 30 minutes. When I tell people about this study in my shop, they lose their mind. They're like, Jimmy, I'm never giving 10 mg per kg. But I really thought this was a good study because it lets you know how deep can you go and what will happen if we give a really big dose. And it looked at the level of ICU hospital admissions from the ED, and they also looked at some other things like continuous lorazepam infusion, hospital length of stay, total amount of lorazepam used, and the incidence of adverse effects. And I thought this was really good for the study. And just some of our baseline characteristics. Again, I won't go too much into all of this, but just knowing that we had the initial their alcohol withdrawal scale that was equal between the two, and we also had a time to study drug administration of about 2 hours in both groups. So it really helped me understand where I'll be adding this in this patient population. And the patients who were prior alcohol withdrawal admission to the study was again about the same, close to half in both groups. So what did they find? They found in this study that the ICU hospital admission was with phenobarb versus placebo was 8%. So again, when those patients got phenobarb up front, they really dropped their ICU admissions, and the difference was 17%. And then we're looking at some of the other secondary outcomes, we saw a similar trend. We saw the use of continuous infusion drop tremendously with a difference of 27%. The total diazepam requirements, again, 26% versus 49, about half there. There was no differences in the telemetry admissions or floor ward admissions, and there was a trend towards lower median ICU and total hospital length of stay. Again, when I look at the hospital, when I see 76 hours compared to 118, it lets me know that there's something that's there, again, but we just need a better study design. And we're looking at 34 hours compared to 94 hours. That, again, lets me know that something's there, but we need just a little better study design and add more patients to define if there's a real difference. But again, the stats just didn't necessarily pan out. When looking at the adverse effects, this was the key thing for me. If we gave a big dose, a whopping dose, just a huge dose, 10 mg per kg, none of my providers have ever let me give 10 mg per kg. What happened? They found no difference in incidence of intubations. They found no difference in seizures, mechanical restraint, bedside sitters, and there's no falls or morbidity reported in the group either. So we found that we can reduce the continuous infusions. We found that we can reduce the ICU admission rate, all of that in this study without seeing an increase in intubation. So that's the big worry everyone has. And this study, at least for the most part, shows that we may have something here. So cool thing, it was randomized, prospective, and it actually looked at stuff that we care about, clinically relevant study outcome. And of course, some of the limitation was the fact that there was no formal sample size analysis, small center, single center, delirium, respiratory depression, ECOH level at baseline, and hypertension was again missing from the analysis. And my takeaways from all of this was that phenobarb is an option as adjunct to benzodiazepines and alcohol withdrawal, and 10 mg per kg, that whopping dose, did not lead to significant increase in adverse effects compared to the standard of care. So this next one was, it tackled a different question. This was done by Dubey and colleagues, and what they looked at was, instead of just whether it was in an ED or not, like the previous study, what they looked at was they wanted to compare patient outcomes in critically ill patients with alcohol withdrawal, regardless of their admission to ICU diagnosis, that was treated with protocolized versus this non-protocolized approach. And that was the cool thing. We'll look at some protocols later on, but they want to look at that difference and see, and we are going to be responsible for making these protocols in most shops. So I thought this was a pretty cool study that can help us define whether we should do it. So of course, it's a retrospective pre-post study, and they looked at 135 patients with suspected alcohol withdrawal symptoms admitted to the ICU. When looking at their inclusion, just patients that were 18 years or older admitted to the unit, and then they excluded patients with severe brain injury or low GCSs. The pre-protocol, they looked at patients that particularly received continuous infusion or scheduled doses of benzodiazepines per physician request. And then the post-protocol was escalating doses of diazepam and phenobarbital according to their protocol. And again, we will check that one and many others out later. Primary outcome was going to be ICU length of stay. And they looked at a host of other things: mean and median benzo use, mean and median phenobarbital use, duration of sedation, requirements of mechanical ventilation, vent-free days, and requirement for mechanical ventilation due to alcohol withdrawal. We're looking at their patient population. Again, most of these patients were in their mid-50s there. Most of them was male, of course. 40% in the pre-group had a history of alcohol withdrawal. And then we're looking at history of seizures, it was about 20% in both groups. But the big thing is that their mean SOFA score, like how sick they were, was a little different. That pre-group's a little sicker compared to their post-group, so I thought that was intriguing. So what did they find? What was the big deal? What they found was that those patients in the post-group, again, they had shorter length of stay, ICU length of stays. So 9.6 days compared to 5.2 days. Again, that was statistically significant. the time on event was tremendously lower again, 5.6 days compared to 1.3. Ventilator-free days, again, 26% compared to 21%. And then intubation due to alcohol withdrawal being 5% compared to 22%. And need for continuous sedation, 24% versus 55. And duration of sedation, again, 3.5 days versus 10.8. All of this statistically significant. All of this in favor of their protocol. And I know you guys are saying, Jimmy, there's so many things that can lead to this. But one of the things that I'm thinking about, if we're already using benzos in the past and we protocolize this thing, we make it to where we add phenobarb on top of it, look what we can get. We're seeing about half of everything here. We're looking at the intubations being 5% versus 22%, a host of things that are being beneficial if we, as pharmacists, make a protocol that potentially can use phenobarbital. And then looking at deaths, again, there was 3% versus 12%, but again, it was anything that we can find statistically significant. So another cool study, again, with clinically relevant outcomes and provided a protocol, tons of limitations, so again, retrospective, small, senior center, all the other things that we care about wasn't here like it was in the previous. And phenobarb, again, for me, is just another option that we can use as adjunct to phenobarb, to benzos. And it is definitely, a protocolized approach is definitely needed. And this may actually reduce ICU length of stay. So again, I looked at those. There's many other studies as well that we can find. And what we found across the board, we just go through this first study here, looking at 78 patients, and they used lorazepam based protocol versus the phenobarb first, then that benzodiazepine protocol. And what they found was that those patients, actually no patient in the group required intubation or hypotension. This thing is getting in my way here, sorry guys. That there's no difference in the daily lorazepam requirements in the hospital or hospital length of stay. But those patients that got the phenobarb plus lorazepam group actually had an increase that was discharged within 72 hours. The next study I looked at was another retrospective study that compared this benzodiazepine only versus this phenobarbital base group. What they found was that there was no major difference in their adverse effects, but there was an increase in delirium in the benzodiazepine group. Looking at the Nelson study, again, another one that was pretty cool. They looked at diazepam alone versus lorazepam plus phenobarbital versus phenobarbital by itself. And what they found was no difference in ICU length of stay, ICU admissions, and need for intubation. But phenobarb was actually associated with an increase in ED length of stay, but benzo requirements were reduced. So again, this may be challenging for you guys to see, but one of the things I'm always trying to power through is figuring out whether or not that I can find a protocol that can help me out, because I'm always getting asked to make a protocol. And let me see if I can get something drawn here. Now it doesn't look like, if you start at the top here, they go down based off their moderate, severe risk, and then based off there, you start your symptom base. And what I found was they had those real, sorry about that, guys. Escalating doses of diazepam with 10, 20, 30, 40, you know, across the board. So you have like really big doses. You maxed out at 120 milligrams. And if you maxed out, then they gave you escalating doses of phenobarb at 60, 120, and 240. So that was a pretty aggressive, I would say, protocol that they used. And it was just something that I thought, like, man, you know, we can utilize something like this to benefit our patient population if we want to switch over to adding phenobarb in our group. Another one, and then someone may be very familiar with this protocol here, was looking at whether they had a severity alcohol withdrawal scale. And based off that, they either got, in our group, they got just 2 of Ativan, Q30, and then they went over, again, as they increased severity, you would add on 260 of phenobarbital in the moderate group, and you follow that up with lorazepam. And then for those patients that were severe, they got a big dose. So those patients got 650 of phenobarbital over 15 minutes. And then they followed that up with lorazepam. And then there's no initial one, they got 260 Q15 at PRN with a max of 3 doses, then it went down from there. Another protocol that I found was done by Ohio State. Again, this may not be the most recent, but it's what I found out there in some posters, was that depending on the level of sedation or respiratory compromise, if they're a low risk, they got the 10 mg per kg. phenobarbital separated into 3 IM doses on day 1. Then it went down to do more, but again, that's the 10 mg per kg what we're going to see in the ED. And then for those patients that are high risk, whether they have respiratory compromise, being elderly, having COPD, things of that nature, they got a lower dose broken down into 3 IM doses on day 1. So I thought this is another cool protocol that we can, again, think about using on patient populations. All right, so I'm going to pause here and get our first poll question. So bear with me as I go through this. All right, there we go. So true or false, do symptom trigger therapy with benzodiazepines lead to equal efficacy outcomes without compromising safety? I know Lance is smiling, seeing this protocol in here. All right, I'm going to go ahead and end that one here. Again, 71% of you guys said that it was true. Here we go. Yeah, 71% again, from the data we presented earlier, symptom trigger was going to be just as effective as just the standard therapies. Alrighty. And then my last question here, and get my poll back up, was in the study presented, is there a reduction in ICU length of stay and benzodiazepine requirements with the use of phenobarbital? I'm going to go ahead and place that in there. This one should be. Let's see if we can get to 200. I'll cap it there. And of course, 93% of you guys said it was true, and that was definitely the correct answer. So I'm gonna stop sharing. Let me see if I can get myself in the. Perfect. So just to summarize, and I hope you guys can see my screen still. Severe alcohol withdrawal presents a unique set of problems for patients in the ED with phenobarbital-based treatment of alcohol withdrawal seems to provide comparable benefits to the traditional benzodiazepine-based treatment therapies. But again, I think we need a little bit more data to figure out the dosing regimen in the patient population that actually benefits the most from phenobarbital compared to benzodiazepines. Get out of his share here as Cal put up the CE